uh, like Kawasaki's and SLE and Sojia. For this very interesting topic, we have Dr. Chetkara, the eminent clinician and senior pediatrician, one of the most senior pediatrician in Delhi. I welcome you, sir. And to our panelists for this session are Dr. Narendra Bagri. Welcome, sir. Dr. Alok Gupta, senior pediatrician working in Ghaziabad in East Delhi. Dr. Anu Gulati, ma'am, please. Welcome, ma'am. Dr. Anju Singh. Dr. Anju Singh, ma'am. And for this session, I would be inviting Dr. Prachi Jain, the hematologist at Max Hospital, to chair the session. Dr. Millie Ray. Dr. Millie, cardiologist at Max Hospital, pediatric cardiologist. And Dr. Vineet Jain, sir, very senior pediatrician working in East Delhi for more than 30 years. Dr. Chetkara, sir, please. Dr. Sir, वो आए नहीं.
अंशु.
Dr. Anju. हाँ जी. मैंने कॉल भी किया था. She said I will be reaching. I'll call again.
It's okay. So, good morning. And since the time is very short and the cases probably are going to be a little long, I have one rheumatologist meeting missing. So, I thought since most of them would be non-infections and on to other specialities anyway, so we have Alok, who is heading a hospital and is a general pediatrician like me. We have Narendra and Anju. So Anu, so they are rheumatologists. The title mentioned in your program is an answer plus the kunji, question and answer. So we don't bother about the answer which is given Kawasaki or all of us as pediatrician, if you tell me the diagnosis, I'll rattle out the treatment. But reaching the diagnosis is really difficult. So that is what we are going to address. And treatment protocols we all know. But there are problems with treatment protocols that must need to be thrashed for us to resolve the matters. So remember short-term fevers, we are all expert in this. 60-70% of our OPDs are only short-term fevers for different reasons. And it is very easy to diagnose. There are always 5 standard differential diagnoses. Tropical fevers, influenza-like illness, enteric, UTI, etc. And what helps us in diagnosis is the local epidemiology. If I am in the midst of a dengue outbreak, I know 90% are going to be that. And so on and so forth. But what troubles us is a fever which is prolonged, invariably more than 1 week. By that time, either the patient or the general practitioner or the general pediatrician, they already have got them investigated, and our favorite is that CBC CRBs which are done. So most of these routine investigations are normal, and then the problem is whether we are dealing with an infection or we are dealing with a non-infection disease presenting as fever. So 50 to 60% would only be infections. So today what we are going to discuss are the 30 to 40% of these which are going to be non-infections, but invariably most of them are treated as infections. So antibiotics are misused. Remember, we have been over the years trained to do individual or solo practice. Those times are gone. It is always now a teamwork, especially with these complicated cases. So let me go on to the first case. 2.5 years, this case was only 2 months back, admitted with us. 2.5 years, male child admitted with documented fever for 2 weeks, intermittent 3 to 4 spikes per day. Prior to admission, he had cough for 3 days, which was mild, nothing very significant, poor oral intake. And all most of the other history we would have taken for these PUs, rashes, joint pains, skeletal issues, GI, breathing. There was no localizing signs, normally developed, no history of contact. This child was earlier admitted to a hospital with acute gastroenteritis and received lot of antibiotics. You see this mono, mero and amikacin. Also received steroids and anti-malarials. If you remember, we had aqua regia during our chemistry in school. सब कुछ मिला दो. हम उसको पंगा रिजिया कहते थे. सब कुछ मिला दो या भड़ाक होगा या कुछ नहीं होगा. So this is the usual treatment which invariably all these patients of PUO come to us with. So on 18th day, we admitted to our hospital. Examination, irritable child, bilateral conjunctival congestion which was bulbar, single solitary lymph node 1.5 centimeters left neck, rest all was normal, vitals were normal, systemic was all normal except liver which was 2 centimeters within normal range. Over the next 3 days, the patient developed a right intranuclear facial palsy. ENT examination was normal, there were no ear issues. Now, Narendraji, any clues from here? 18th day, 3rd week of fever now.
Okay, fine. So to summarize, I feel that this is a child with prolonged fever, day 18, despite receiving antibiotics. So I assume that we are dealing with an inflammatory stage. That's number one. And why I'm saying so is because of the prolonged fever, which is not responding to the usual antibiotic, and probably you have covered the possible common infections as you have highlighted in the first slide. So it's an inflammatory state. And now coming to the inflammatory state, what could be the possibilities? I would like to keep a possibility of an inflammatory disease at 2.5 years of age with this presentation, and there are certain clues in the clinical examination. Conjunctival congestion, may I know, is it purulent or is it non-purulent?
Pardon?
The pattern of conjunctivitis.
It was just prior to admission, there was no eye discharge and
Okay.
bulbar conjunctivitis.
So that's an important clue.
Yeah.
And the second is also the child is having facial nerve palsy. So I feel that this is something post-viral prodrome inflammatory state and could be an inflammatory state like a disease known as Kawasaki disease, which we all are aware. So that is my differentials in this child.
Okay. So what do you suggest now? I'll show you the investigations which have been done in the earlier 2 weeks. So reasonably in a very good hospital, was evaluated thoroughly. If you see the counts, except for the fag end of the admission, they started rising with a polymorphonuclear response and the platelets were sequentially increasing. That's one. CRPs were high. LFTs, KFTs, not something which is contributory. Albumin was borderline 2.9. Triglycerides high. Fibrinogen high. Ferritin high. These are all acute phase markers except for the fibrinogen which was there. KFT is normal. Chest X-ray normal. Ultrasound abdomen normal. Blood cultures no growth. Echo done on day 7 of prior hospital admission, but on day 10th of illness were absolutely normal, including the arteries as well as the ejection fraction. Baseline investigations at our institute, 14th of April, leukocytosis, polymorphonuclear, platelets increasing, CRP very high, triglycerides, ferritin almost the same. The question is, then we investigated for all the infection markers. I would not go into the list. We scanned for whatever we could lay our hands on. Typhoid, indolent diseases, brucella, everything was done. Cardiac markers normal. Incidentally, since the child had a respiratory infection prior to admission, our upper respiratory PCR was HMPV, that notorious metapneumovirus which you have been listening. Immune parameters like ANA, C3, C4 normal, ultrasound just mild hepatomegaly. We did an MRI brain and angio, MR angio, NAD because of right facial palsy. Now what next, Narendraji?
Yeah. Can you go back to the previous slide, please? So I think the answer is here. So the message from this particular slide is not a single point of counts or any value is important. What is more important is the trend of counts. And if you look into this, we can see that there is probably the hemoglobin is falling. And the most striking feature, as you have highlighted, is again the pattern of counts. You can see that neutrophilic leukocytosis, and the counts are, to begin with, they were somewhere around 11,000 and later on hiking to 25,000 or so. And apart from that, one of the another important clue is see the trend of the platelet count. Again, the platelet count has shot from 1.6 to 10 lakhs, and this is thrombocytosis spanning in over a period of 2 weeks or so. So neutrophilic leukocytosis, thrombocytosis, and the CRP more than 100, and to the last CRP values are 200 or something. We do get elevated CRP in infections, but as you are told, we have ruled out infections in most of the cases, and in this particular case, and at the same time, the cultures are negative. We get elevated CRP, but such high CRP in setting of neutrophilic leukocytosis, thrombocytosis, febrile child, I would like to keep a possibility of Kawasaki disease as the first possibility. And then, can you move on to the further? I'm not, next slide.
So what do I do now?
Okay, so I think you can just keep a possibility of incomplete Kawasaki disease. Probably the child is 2.5 years of age, irritable, conjunctival condition, so he's not meeting the all classic 4 textbook criteria of Kawasaki disease.
We'll come to the diagnosis of Kawasaki.
Okay.
So you say incomplete Kawasaki.
Yeah.
Do I need to repeat echo now, which is 10 days to the prior echo?
Yeah, I